interests of their patient with full information to the patient. Promotion means something rather specific to us, and there is no ability to advertise a medicine which hasn't been approved. The committees may know that we took careful steps before the particular approval this week to make sure that the availability of a COVID-19 vaccine through our temporary authorization of supply in the pandemic could be particularly the subject of appropriate promotion.
And if so, in my experience, certainly unlicensed products have been used, but in that circumstance, what kind of information would you expect to be passed to the person who was subject to the use of that product before an unlicensed product was used for the purposes that are unlicensed?
May I first stress that the COVID-19 vaccine, which has been subject of temporary authorization, has met full standards.
I'm sorry, I should be clear. I'm not talking about the vaccine, I'm talking about general principles.
In general terms, the expectation would be that the healthcare professional would share full information with the person who they judged met the need to be met by an unlicensed product, and that they would take full responsibility to monitor safety. They would record that conversation and the necessary point that the person would be aware that it hadn't been licensed for that particular use. There is good advice, and we have provided that advice to healthcare professionals around this issue, particularly so that there isn't a barrier, but the obligations are very clear for best practice. And I would expect the healthcare professional to be clear that what they were advising was something that any member of their profession would be able to say is evidence in terms of their experience.
Thank you very much. If I make one very final point, Chair.
Very quickly, Neil.
In terms of gathering evidence on that product, which it may be done, would you expect that evidence to be gathered using a specific protocol, a research protocol?
That would be a most useful thing to do. It's not a requirement, but we do expect any company who's marketing a product aware of unlicensed use to gather data and submit it to us, data on safety and effectiveness in the normal way.
Thank you very much.
Thank you very much indeed. Can I thank Dr. Rain for coming today? You've got a lot on your plate. You've got at least 2 other vaccines to direct and review the work on. We're very grateful for you helping the committee with your reflections this morning. I hope you'll come back perhaps in the new year and reflect at some greater leisure on the achievements and what were the components of that, so that we can advise our successors on this. But thank you very much indeed for joining us today. We're now going to move on to direct our questions to Sir Patrick Vallance, to Professor Whitty and Dr. Harries. Thank you again for coming. Perhaps we can start with this question of vaccines. And Sir Patrick, you're the government's chief scientific advisor. I know that you have been personally, intensely involved in the whole move to develop vaccines from the outset. So perhaps your reflections on what are the components that have allowed us to make this great start ahead of much of the world in terms of the assessment of the vaccines.
It was my assessment, and other people's as well, very early on, that trying to get a vaccine was going to be a really important part of approaching this disease. And in order to do so, recognising that many vaccines fail and there had not been a successful vaccine against any coronavirus, human coronavirus before, it was going to be necessary to look very broadly across the world at what was happening and to look at a diversity of approaches, because there are many new vaccine technologies. The Pfizer-BioNTech one is one example of a so-called messenger RNA vaccine, which means that the landscape for making vaccines quickly has changed quite radically. in the past 5-10 years. So early on, building on, I should say, some very important things that were done prior to all of this, which include things like setting up a vaccines trial network that Chris may want to speak to, long-term investment in the science of vaccinology and the related disciplines in the UK, meant we had a good baseline of expertise. What we did want to do, though, was to bring together people from industry as well to make sure that we had expertise in manufacturing in particular, because very often with a vaccine, the problem is even when you've got it, it's difficult to make it and to make sure you can get it out in the right quality at the right time. So we brought manufacturing people in, people from industry, academics and others, to set up a vaccines task force to try and say we need to log what is going on across the world, which ones we think might be the most promising, and to work out how we would then support those where it was appropriate to do so, such as the UK ones and other ones which we thought needed support, and to work out mechanisms of access where we thought that would be necessary. So that was really the vision behind the Vaccines Task Force, which Kate Bingham then came in to lead so successfully. And it was important we did that because we haven't got a domestic vaccine manufacturing base in this country, or indeed a domestic company that is making and discovering vaccines in this country. I mean, we've clearly got companies that do that, but they're often done elsewhere in the world rather than in the UK. So we knew we had some domestic resilience to build up. The VMIC, which has already been referred to, is part of that, but it was broader as well in terms of so-called fill and finish, which is the final part of vaccine, where you fill the vial itself. It sounds trivial, it's not. It's very complicated and has to be done in certain circumstances. And we knew that some of the new technologies, such as messenger RNA vaccines, would need ultimately specialist facilities in order for them to be made. So it was a rather comprehensive look at this, early on, systematic, linking to those companies across the world that we thought were doing this right, and making sure that where appropriate we got options on vaccines. The other thing I would say is that very early on we recognised that vaccine nationalism was not the answer here. We had to get ourselves sorted out, but vaccines need to be available for the world because ultimately this is a pandemic, it's in every country. And so as part of this, we were also very keen on initiatives through the WHO and others, such as COVAX, to try and say, how do we become part of a global solution to make sure that doses, money, expertise was available for others as well? And that, I think, has been an important part of this. So I think it was a very comprehensive approach. Again, June Rain has spoken about agility, flexibility and scientific expertise. Those were the things that were brought in the Vaccines Task Force to try and do this in collaboration as quickly as we could, knowing that it would be necessary to get access both for the UK and across the world. And then the final point I'd say is, in all of this, it's been important to have links in other countries, and so we've had links with the Warp Speed program in the US, in others as well, to know what's going on and how we can share information, share approaches where appropriate to do so.
Thank you very much indeed. Well, lots there that might have wider applications as we look to learn the lessons here. Internationalism, anticipating future needs, having a spread of possibilities that we are associated with, not knowing which is going to come right, paying attention to the kind of physical and sometimes logistical aspects as well as the intellectual property. These are all themes that I think have a wider application. Let me turn to Professor Whitty, and clearly the clinical trials side has been an indispensable component of this success. Well, what are your reflections from the vantage point of today?
Well, I mean, I'd make 2 points. In a sense, Patrick's talked very clearly about the period for this year leading up as part of the Vaccines Task Force. I'm going to go back a bit in time and then forward a bit in time. I mean, with back a bit in time as to how do we get to where we are, you could go all the way back to Jenner. I'm not going to, but I would like to go back to the Ebola crisis. Because in the Ebola West African crisis, which I was heavily involved in as part of the Department of International Development, one of the things that was clear was that there were vaccines that were very near endpoint but had not been properly progressed, and therefore we had to manage the Ebola crisis in West Africa in support of the government of Sierra Leone very much entirely around case finding and isolation as the principal tool. Because we didn't have a vaccine, but vaccines had got to quite a late stage of preclinical development. And what we realised is we needed to be able to accelerate vaccines through. And so although, absolutely to pick up Patrick's point, science is an international discipline. It is not we all have to do our parts, but it is an international discipline. But we set up, and the person, this was the initiative of the then Prime Minister, David Cameron, and Sir Oliver Letwin, who I think drove a lot of this, put into the Department of Health, under actually Mr Hunt at that stage, a UK vaccines network. I was asked to chair it, and I've carried on chairing it since then. And the aim of that was to identify diseases that were not flu. And I was very clear on that point. They were not flu, because I thought there was a lot of thinking about flu. It was really important to think about all the other diseases. And we did three things. We looked at, we basically prioritised all the diseases that we could predict might need a vaccine. Obviously, number one was disease X. We haven't yet got it, and that is indeed what we got at the moment. Number two was, in fact, MERS, which is a coronavirus still circulating in the Arabian Peninsula. And that was very important, actually, because we then invested in some early MERS vaccine work in Oxford, and that was some of the base science that helped them to move so fast onto the Oxford AZ vaccine. So that's an example of the sort of thinking ahead helping us. Of course, you couldn't predict this particular one. So that's one area. And then a second initiative on a larger scale internationally set up, and I'd like to pay particular tribute on this to Jeremy Farrar, was something called the SEPI initiative, which was a large multinational approach to novel vaccines, again for epidemics. I was on the interim board, so I was when it was first set up, so I had some understanding of this. And this is an area where, again, internationally, we try to identify the kinds of vaccine targets, but also the kind of vaccine platforms, the different models of vaccines, to develop them as much as possible, so that we had a wide toolbox for when something happened. And these kinds of precursor activities, plus a huge amount of basic and translational science, allowed us to advance. And then when it came to the trials in the UK, we were able to use the National Institute for Health Research, NIHR, clinical trials network, which allowed us to do trials in multiple sites very fast. And that was both helped us with drugs, and the drug things we've done. The UK's response on clinical trials for therapeutics has been extraordinary in international terms, and for vaccines have again used this pre-existing system. And then if I can skip forward to forward-looking, Dr. Rain talked about identifying things once a vaccine is in use. The initial process, very importantly, picks up common side effects. That's what the big phase 2 and then subsequently, if they're safe, phase 3 clinical trials allow to happen. But extremely rare but important issues, inevitably you accrue more information over time. And the NHS, through to the MHRA, is in a very good position to make sure that we can pick things up quickly, identifying them, communicate them widely, ensure that we improve practice. So there's a backward-looking bit and a forward-looking bit for these vaccines, and they all depend on pre-existing systems.
Thank you. That's very helpful, very comprehensive. Just finally for me on this, we've been thinking about the structures of scientific advice in government throughout the pandemic. Was SAGE part of the response in terms of developing vaccines, or was it outside the SAGE structure?
Are you talking about in this
pandemic?
Well, why it wasn't Patrick was the main chair. Patrick and I can add.
I mean, it's not really a SAGE issue in that way. So the SAGE would have a view on vaccines from some of the experts around the room, but this was about getting things set up, operationalised, getting the science into practice, which is different from the sort of science advice that comes through SAGE. And it also demonstrates a general point, which is Because SAGE has been so visible, a lot of people assume that SAGE is the only form of science advice into government. Of course, it's not. It's a particular form that brings together things to address questions that cross multiple departments and so on. This was a focused activity that needed to take place, and that's why I was so keen to get a vaccines task force really working on this with the right experts at the right time, including, and Dr. Rain alluded to this, making sure the regulators were plugged into this extremely early so that we weren't sort of doing what often happens, which is you develop something and then something gets thrown over the wall and caught by somebody else.
Thank you. That's very helpful. I wanted to establish that not all scientific advice during the pandemic has been through the prism of SAGE. There have been multiple ways in which
there are lots of other big organisations, of course, that are scientific operational groups within government that have dealt with things as well during this epidemic.
Absolutely. Thank you. Dean Russell, next.
Thank you, Chair. And may I also say how fantastic it is about the news with vaccine, and thank you for all the work you've both been doing to drive that forward. I have a few questions around the preparations moving forward. And firstly, could I get an outline, just a real clear summary of what the next year looks like in terms of the rollout, please?
Who's that to, Dean?
Patrick Vallance.
Sir Patrick.
Rollout of vaccines.
As in terms of, how we're going to get it to the right people at the right time. Obviously, there's a rollout in terms of vulnerability. Yep. But who's going to be doing those vaccines? Especially, we're going to have to. There's several million people are going to have vaccines. Is that going to be GPs? Is it going to be hospitals? Who's going to be administering them? I'd just like to get an overview of what that will look like.
So I think Sir Patrick is going to tell me that this is an NHS matter, and therefore the Chief Medical Officer is probably best placed to answer this.
Okay.
Professor Whitty.
So this is an NHS matter, so I'm going to, in a sense, although the NHS obviously has independence, I'm going to speak in broad terms about the kind of approach they're like to take. The first thing to say is that the only current vaccine for which we have emergency authorization for use, which is the Pfizer one, has a very complicated cold chain system at having to maintain it at -70 or below. With relatively small numbers of, so in a sense, changes of hands. And that makes it rather harder operationally than some of the potential subsequent vaccines that might come through. The AZ one we've talked about already, but there are several others that will come through, I think, from a variety of sources later in the year. So the first thing is, this is much easier to operate through hubs. But the aim would be to take it out through the system as far as we can. And this is true in all 4 nations of the UK. And of course, we talk to one another the whole time and try and coordinate our activities as much as we can. When we start off with vaccines, I'm always very keen, as with any other drug, is you want to take things a little bit more carefully to begin with, just so you get to know how these things work. So, for example, Dr. Rain talked about the fact that we were discussing 2 early cases of things. I mean, she and I were discussing this at 11:30 last night, just to make sure. And you start off, in a sense, doing it in centres where actually you've got all the equipment and everything, and then as you're comfortable with them, you feel you understand them, you move them out, and that's part of the kind of standard where you'd think about safety of things. But the aim would be to roll out this vaccine and then any others that get a licence and are effective and safe. And we expect by the middle of the year probably to have a portfolio of 3 or 4 vaccines which we can actually use. And then the first question will be, provided all going fine, no late tumbles in terms of side effects which the regulators find or anything of that sort. The second question will be, the first question is, who do we do it? And the Joint Committee on Vaccination and Immunisation, JCVI, has done a prioritisation list, starting with the most vulnerable and those who look after the most vulnerable as a way of protecting those. So care homes, then people over 80, then people over 70, plus care workers and healthcare workers, and so on, down a list all the way down to people over 50. And we just go down in stages because this disease is one that is very predictably much more dangerous for older people and people with pre-existing health conditions than others. Once we've gone through that first list, which takes us down to roughly 20 million people, then there's going to be some wider choices to make about how do we go from there on. And those will be important ethical and political choices as well as clinical choices. But the first choices are, in a sense, make themselves because they're the people who are the most at risk. And then the final question, and then I'm happy to obviously expand on any of these, is do we need to revaccinate people, and if so, when? We don't know how long we know that these are very good vaccines to provide short to medium term protection. We don't know how long that lasts. It might last for a very long time. It might last for 9 months. I think it's more likely to be somewhere between those two. And in that case, we may have to have a situation where we have to be in a position to revaccinate, particularly people who are the most vulnerable. So I think all of these we'll have to think about as the information comes out on length of effect, efficacy, safety, and so on, and which vaccines best suit which people.
Thank you. Dean, quick follow-up?
So I was going to ask that actually, which was, are we going to look at an annual vaccination programme, which by the sounds of it is potentially the case. But in terms of a good rate of vaccination, if we're having this same select committee in a year's time, what would be a good result for you in terms of the percentage of the population been vaccinated?
Well, in terms of so to answer your first question, whether we need to revaccinate and how often, we don't know. And there are broadly two reasons to revaccinate, one of which is the immune system wanes. So the same vaccine used repeatedly, but you still have to revaccinate. The other is the genetic thing that you're targeting the vaccine against shifts. The infection evolves around the vaccine. This is what happens with flu. Then you have to reformulate the vaccine and then use a slightly different vaccine to deal with the new version. So those are the two situations you might need to do it. In terms of what looks like a good response, absolutely the first priority is to provide protection for the people who are most likely to come to severe ill health, potentially die, certainly could end up in hospital with severe problems. And those are predictable based on the numbers. But some people who are younger, who are not predictable, will still get very severely ill with this infection. So we would want to go down further than that, but start off with the most vulnerable. But that's all about protecting the individual who has the vaccine. There's then a second question to which we do not yet know the answer, which is, do these vaccines, if you vaccinate someone, does that mean that you protect the people they meet? Is this a transmission-preventing vaccine? And we don't yet know that. Now, my expectation is that it will be to some extent, but whether it's a small amount or whether it's a large amount is not yet clear. If it's something which only provides individual protection, and some vaccines do only provide individual protection. Tetanus vaccine, for example, only protects the person who's vaccinated, protects no one else at all. So in that case, you're really trying to make sure it's the most vulnerable. If, on the other hand, it's something which protects everyone around you, then it is strongly in the interests of everybody that as many other people are vaccinated, because then it means that people where the vaccine isn't working, where they can't take it, where they've chosen not to take it, they are also protected by the fact that people around them have immunity and therefore are not going to transmit disease to them. But we don't know that yet, and I think it would be a mistake for us yet to say we're going to try and achieve this kind of population immunity because we're not confident yet whether that is something which is biologically possible. I think it's likely, but it's not definite.
Thank you.
So with that being the case then,
very briefly,
with regards to the thing that everybody's looking at for the vaccine is around when we're going to come out of lockdown. I think that's the light at the end of the tunnel. At what point, if it's the case that the vaccine only protects the individual and not others from transmission, at what point does SAGE recommend actually lockdowns are no longer needed? Has there been conversations on that point yet?
Well, I'll give a view, and then Patrick will want to give a view. But my view on this is what the vaccine will do for sure, even if it has no onward protection advantage at all, and I think that's unlikely. I think it will probably reduce transmission, but let's assume it doesn't. But what it will do is incrementally, it'll first reduce the mortality rate very substantially because the mortality is very heavily skewed towards older people. So once you get through that, it'll really substantially reduce it. And then it'll start to reduce the number of people who go into hospital and have severe disease very substantially. And at a certain point, society, through political leaders, through ministers, elected ministers and through Parliament, will say this level of risk is a level of risk that we think it is appropriate to tolerate, just as we accept that in an average year 7,000 people a year die of flu, and in a bad flu year 20,000 people die of flu. That's just, we accept that as that is what happens biologically. And at a certain point you say actually the risk is now low enough that we can largely do away with certainly the most onerous things that we have to deal with. This will happen incrementally. It's not going to be where absolutely everything till one day suddenly you stop. This will be a kind of gradual retreat from that, but it is a de-risking process rather than it's just going to go away. And we will de-risk hopefully to a very low level of risk, but I think it's very unlikely we'll get to zero level of risk. Now, SAGE can help, and this is where I'll turn to Patrick, can help in saying what level of risk there is. It is ultimately a societal and therefore a political question: what level of risk does the population wish to tolerate relative to the damage that is done to other areas, to the society, to the economy and so on. Those are the difficult choices. We're not there yet. For the next 3 months, I want to be very clear, for the next 3 months we will not have sufficient protection. We're going through the most difficult time of year for respiratory infections and the most difficult time of year for the NHS. So the idea we can suddenly stop now because the vaccine's here, that would be really premature. It's like someone giving up a marathon race at mile 16. It would be absolutely the wrong thing to do. But there will come a point where the choice about exactly when to start to ramp things down, how fast and which, needs to be made. And that is fundamentally a science-informed political decision.
So Patrick, briefly, anything to add to that?
I agree. It's a science-informed political decision, and what we're looking at is exactly that sort of question as to, depending on the effects of the vaccine on transmission, which we don't know yet, as Chris has said, you would have different models as to what that would mean in terms of the degree of immunity across the population you will end up with that will be relevant to keeping suppression of transmission versus protecting those who are most vulnerable. So priority number one has to be protect those who are most vulnerable. You can see the effects of that. There will still be transmission amongst others at that point, so we need to be aware of that, and then we will know a bit more as we learn about transmission across the different vaccines, what effect they have. But ultimately then there are some decisions to be made about how much risk society wishes to take with that.
Is there, assuming that there, perhaps pessimistically, that there isn't a prevention of transmission, it's protection of the individual, what would be a kind of reasonable threshold proportion of people vaccinated for that conversation to start as to removing the social distancing measures?
I think this is ultimately a political question, but I would certainly think it would be I think very few people would recommend having starting to really remove things when during a high risk period of the year, which the winter always will be for respiratory infections, until you got that initial the tiers which the JCVI has laid out covered, because those are the ones who are by far the most likely to die, and they're the ones who are by far the most likely to end up in the NHS. That does leave a lot of people who could, for example, have all the syndrome of things that are currently called long COVID. There are a variety of other medical things. It's not that will get rid of the problem completely. Once you got to that stage, I think a conversation about now what do we want to do next becomes a really important conversation. Of course, you can have the conversation in advance of that, but I think most people would want to see that level of protection happening. And if you only were to vaccinate those 20 million people, the numbers are rough, but for the sake of argument, you're still going to have a lot of people who are susceptible. So that will not produce population immunity, even if it prevents transmission. So what that will do is substantially reduce mortality, significantly reduce the impact on the NHS, but it will still leave a lot of people who could become ill with this and could, in some cases, have serious outcomes.
Absolutely. As we talked about before in this committee, the concern for the NHS being overwhelmed has been an important driver. So once we get to that point, then you can have that conversation as to the balance of harms and advantages of a different regime.
Yeah, but I would go back to my point that I consider that to be a question for ministers and elected politicians on behalf of society. We can inform them with saying, if you do this, this is what will happen, we think, and if you do this, this is what will happen. But that is a societal choice. I don't think medics or scientists should make that final decision.
That's very clear. Thank you very much. Rosie Cooper.
Thank you, Mr. Chairman. To Professor Whitty, we know that the UK secured access to several vaccines. Are there implications to having those different vaccines in circulation? And how would we determine who gets what? And will the population have a choice? I would want a choice. And would it depress vaccination rates if people aren't allowed to choose?
Well, I think getting to a situation where we have enough vaccines that you have a choice which one you wish will be a very nice problem for us to have. It is not the problem we have at the moment, and it is not the problem we're going to have for the next 4 months. So the choice, when it gets to my stage of it's my turn to be vaccinated, and I'm nowhere near the top end of the tiers, so it won't be for a while, and I will absolutely have the vaccine at the point when it is appropriate for me to do so. I will be given a choice, probably, between either having no vaccine or the vaccine that is available for me at that stage, and I'll be very happy with that. If the choice is between no vaccine and a good vaccine, I'm going to choose to have a good vaccine. I don't really have a strong view as to which good vaccine I have, provided it is safe and effective, which is what the whole process that Dr. Rain was talking about at the beginning, and then the subsequent post-authorization surveillance is all there to do. Now, it may be we get to a situation in the autumn where there are more than one vaccines, but a lot of this will be to do with the particular properties of the vaccine, exactly how it works, what the side effects are. There are so many things we currently don't know, and there may be particular people for which particular vaccines are better or worse medically, just as there are for many medical drugs. If you want to bring down someone's blood pressure, there's a choice of about 30 drugs you could use. At some of them, it's basically you just toss a coin, and some of them it's clear that particular people are going to benefit from particular drugs. That may well be the true here. But I want to go back to my first point. That will be a nice problem to have. Currently, if the choice is between a good vaccine and no vaccine, I'm going to just go for whichever good vaccine is available.
Thank you. Rosie?
Thank you. Professor Whitty, you've just indicated that you were likely to have the choice for about 4 months. And later on in your answer, you mentioned the autumn. So if there isn't approval for the Oxford vaccine soon, will there be an interruption of supply? We've ordered 40 million doses of the Pfizer vaccine. What is the supply schedule? And especially the Oxford vaccine, when it comes on stream, we don't currently have evidence of its efficacy in the over 55s. So what is the strategy? How are we going to almost maintain supply over the next 6 months, shall we say?
Well, I'll make a science comment, and Patrick may then want to make one because he's on the vaccines task force, which I am not on this particular issue. The science point on this is that on the AZ vaccine, the Oxford vaccine, it's one particular one particular arm that hasn't been tried in older people with full data. The paper was published in the Lancet yesterday. It bears full reading, but there are people who have had this who are older. So it's not that there is no data on older people. It's just the kind of way the trial was constructed. The second rather obvious point I'll make is, of course, every company which has got an authorised product is going to want to ship as much of it and as fast as it can make it. But these are not trivial things to make. These are significant things, and they've got to be made properly to maintain proper efficacy and safety. You've got to have a proper cold chain and so on. So a lot of this will be constrained by simply what is possible, as much as choice. In fact, choice will be probably a second order question at this point in time. But Patrick, do you want to add to that?
Well, I'm not sure I've got much to add to that, actually. I mean, it is a sort of supply chain issue at the moment, and we need to wait and see where the Oxford vaccine gets to, Oxford AstraZeneca vaccine with the regulators, the Moderna vaccine as well, as Dr. Rain said, and depending on where they get to in the regulatory process and the ability to supply, we'll either have more or less vaccine available. But at the moment, we've got Pfizer with a decent position in terms of the number of doses to get on with the most high-risk people, as we've said.
Thank you. Rosie, one more question?
If I may, could I just press the point about the Pfizer and the take-up we've got currently? I understand that the amounts being given to the major hospital centres is around 1,000 doses currently. So when will they get their next supply? Are you really saying you can, even at this small number, let's say, are you assured of continued supply, or are we going to end up with a gap while we wait for further supplies into the country?
Well, I'm glad to say that the British public in all 4 nations of the UK have the services of some extremely good supply chain people, and I'm not one of them. So I think the sensible answer is that, that's a very fair question, but I don't think either Patrick or I are the right people to ask how supply chains work on this particular thing. But my understanding is there will be a steady stream of these vaccines as the manufacturers can make them and they can be shipped. And we anticipate that being able to move steadily ramp up over the coming months. But we will, in the great majority, as people have been saying several times over the last several days, of people vaccinated will be in January, February and March of next year, not this side of Christmas. And I think we should be really clear about, even if the AZ Oxford vaccine is authorised for use by the regulator, by MHRA, we're still looking towards next year, 2021, before we have significant amounts of supply of those 2 vaccines.
Thank you very much indeed. Now, we've got a lot of ground to cover. We want to turn to the subject of treatments. So if we could have short questions and as brief as an answer as you can manage while conveying the information, that would be very helpful. I'm going to turn to James Davis next.
Chair, can I make just one other comment about vaccines?
Of course, yeah.
Thank you, Chair.
Yeah.
Sorry.
So Patrick just wants to make another comment about vaccines before we
One other
move on.
comment, which is just to reiterate something I said at the beginning. The vaccine technologies have changed so radically in some cases, such as the messenger RNA vaccine in the last few years, that it completely changes the possibility of getting rapid responses to new infections. And that is a point, I think, which is really important to learn in terms of resilience going forward. You can go from the genetic sequence of the bug to the potential vaccine candidate in a very short period of time. Lots of optimization to do afterwards, but that is a new thing which is worth hanging on to as we think about what the lessons are that we need to learn for the future.
Absolutely, and thank you for putting that on the record. That it is one of the most exciting developments and discoveries during this time, and it's really important. We're determined that the committee should highlight these lessons that can be applied, hopefully immediately, for future use. Thank you. So, Dr. James Davis.
Yes, thank you, Chair. Professor Whitty, some moments ago you referred to the UK's response in terms of the development of therapeutics as being extraordinary, but I wondered what your view was as to how that could be improved further still, looking forward to future pandemics.
Thank you. Well, I think let me just say why I think it was extraordinary, because I think it is important that we celebrate the things that have gone well before saying where I think we could improve further. I mean, the numbers in terms of people who are in studies in the UK are quite extraordinary. So yesterday, just to take an example, yesterday the recovery trial, which is the largest trial of therapeutics, reached 20,000 people, UK citizens who'd volunteered to be part of this. Other trials are also ongoing. We currently have 90,000 people under trial, and in total, over 640,000 people are taking part in studies of COVID of some sort or another in the UK. That is an absolutely extraordinary achievement, and it builds on a combination of things: the very strong foundations of the NHS, the very strong funders we have, the National Institute for Health Research, NIHR, which I run, the Medical Research Council, which is in UKRI, and the Wellcome Trust, among others, but there are also the medical research charities, so there's a good funding base, outstanding academic centres throughout the system, and very importantly, a very strong ethics and regulatory system, the HRA, the Health Research Authority, which looks at the ethics before things happen, and the MHRA, which regulates trials in particular. If you don't have those building blocks, it's very difficult to do this. So the fact we've been able to respond so quickly has a lot of building blocks. But the biggest reason is that UK citizens have been extremely generous with their time and prepared to take the slight risk of going into a clinical trial with a new drug or vaccine because they wish to do that for society. And I think they are extraordinary heroes of this, because that, if you just think about those numbers, When we get to the end of next year, I think we'll look back and find that a very high proportion of the research on therapeutics has been done here in the UK, and it's because of all these things coming together. So I think there's a lot to be proud of, and if you look at the number of drugs that have been tried by Recovery, by REMAC-CAP and a variety of other trials, it is a very remarkable number. What could we do differently? I think that the biggest, I think where we demonstrated real speed was on what's called phase 3 studies. We got a great skill set in this. These are drugs which are where you can actually take them straight through to a rapid, large-scale trial. And the recovery trial, which I've talked about, ran out of Oxford. Many people funded it, including NIHR. That has been highly successful, but that takes drugs that are already licensed for other uses. We know a lot about their side effects. We know, in the main, we know a lot about their other properties. And you take them into large-scale trials where you can find things out very quickly. That's been really strong. I think we have been slightly less strong on what's called phase 2 studies, which is an earlier stage of development. And there, I think the key thing is to identify which drugs it is you need that work. And the difficulty here, and what we did fairly ruthlessly, because we had to, was there was only a certain number of people who can go into trials, and we set up at the beginning of this a system for urgent research priorities where we prioritised only a very, very small number of studies and said those are the only ones that can actually happen with full support from the whole system. And that was because what we were really worried about, and what has happened actually in many other countries, was that people would launch 300 trials, no one of which would reach its endpoint because they were all too small. So it was really important to do the prioritisation. But the difficulty is, of course, there are winners and losers when you do prioritisation, and the worry is, are you actually prioritising the wrong things? So I think we were very strong on the phase 3. I think we've been very strong, thanks to the Medical Research Council and others, on some of the basic sciences. I think the phase 2 area, I think we've got lessons to learn, and I think when we come and look back, I think that's the bit which probably we would do better, again, learning from the experiences of time. And that's not to say we did it badly. I don't think we've done it well, but I think we could have done it even better.
Thank you. James?
Thank you very much. So earlier in the inquiry, it was alleged that there'd been poor investment in platforms for developing new treatments, both in this country and worldwide. Would you agree with that comment?
I think probably Sir Patrick, who's got a full industry experience in this, is the best person to answer. I can add to anything he says.
Well, I think we've covered it for vaccines, that there is an issue about manufacturing capability and capacity in the UK, which is being addressed. So that is, I think, something that needs looking at. For therapeutics, as Chris has said, for existing medicines to be tried for a new disease in phase 3, I think the infrastructure worked really well. And I think that's so important, because if you look around the world, there's been pressure in all sorts of countries to say, such and such a drug looks exciting, we should give it to everybody. And we saw that with chloroquine and various other examples. You can't understand what works from just looking at a small study. You need to test things in a big study. And that, I think, is what's been so important to end up with both the positive and the negative results. So clinical trial infrastructure, I think, has been well funded, well supported, and actually worked well. I think if you move on to the question of new drugs, we've clearly got 2 major pharmaceutical companies in this country and lots of smaller ones as well. New drugs take much longer to come through, so I only expect to start seeing sort of really brand new targeted drugs for COVID to start getting into clinical trials, possibly this year we might see some. And that's really in the hands largely of the big companies and the small companies to do that. And there I think the UK actually has got quite a good position, and we'll see what happens in terms of the drugs they may come up with. I will pick on one specific example though. Very early on, it was possible that so-called neutralizing antibodies could be beneficial. Those are antibodies which have been made in the laboratory that neutralize the virus, essentially mimicking what a vaccine does, but doing it by giving the antibody itself. The sequence of the antibodies became known quite early on, what might be useful to look for, And the UK has picked up on that, and companies and others have picked up on it. We do have, again, I think, a deficit in the ability to manufacture these things at scale. And so I think that's an area, again, that needs looking at. The ability to manufacture antibody production is where something's go for. And then the final point is people often say, well, can't you just have lots of drugs ready to go that you screen and you hope that you're going to pick the right one at the beginning? I mean, people always do that in a pandemic. We did it for Ebola, we did it for all sorts of things. It's worth doing, but it's got a low success rate in terms of pickup.
Thank you very much.
I'll add one more thing on this, which is the platform we haven't talked about and is absolutely critical here is the NHS. The NHS in all four nations, well, the NHS and equivalents in all four nations, has a real tradition of doing trials and of being very evidence-based. So when I and the other CMOs wrote to all the hospitals and GPs and said, we don't want anyone doing experimental drugs without trials because trials is the way you do it, that was just accepted as a completely normal thing in the UK. I think that would have been quite difficult to do. In fact, it was very difficult to do in many other countries because of a strong tradition of evidence-based medicine and people doing trials and then paying attention to the results. And I think that has saved us from doing a large number of things in an ad hoc way with drugs that were either useless or even dangerous.
Thank you very much indeed. Neil Handy.
Thank you, Chair. I think it would be fair to say that everyone heaved a huge sigh of relief when the vaccines came on stream and started to be administered yesterday. But we have quite a bit of a journey to go from where we are now until we have sufficient safe levels of immunity. And I want to return to testing and the science of lateral flow testing. We know that the Innova test is not licensed by the MHRA for asymptomatic use, although the Liverpool study did do that. And we also know, as widely reported, that the sensitivity or accuracy of those tests is disputed, and there is a growing chorus in the scientific community raising concerns about that. To get from where we are now to where we need to be and prevent the risk of furthering the spread of COVID while we're so close to eradicating it, do you think lateral flow tests, as they currently stand, have are sufficiently robust to allow for test and release over the Christmas period?
Shall I have a first go? But I think Patrick will want to come on to this because SAGE has looked at this specific area. The thing to understand with all the tests is none of the tests we have at the moment are ideal. You have lateral flow tests which are easy to use in the field but have good specificity, what's called specificity. They don't pick up huge numbers of false positives, which I might come back to that. But they have a lower sensitivity. And then you have PCR, which is a good test, but is tethered to a laboratory and where you have a delay in getting a result back. Neither of those are ideal. Of course, what we would ideally have is a lateral flow or equivalent, a near patient test, which was very fast and entirely reliable. We don't currently have that. So rather than pretending that we can do things that can't theoretically possible, the right thing to do is to say, with the tools, the imperfect tools we have, what is the best strategy? And that's what we're trying to do.
Neil.
Yeah, no, I mean, we understand we've covered the role of PCR and lateral flow test extensively in the committee. And, you know, I'm not asking for advice about that. I'm talking specifically about the use of an unlicensed test for asymptomatic testing and the clinical data that supports that and therefore informs political choices. So this is really about the rigour and reliability of the clinical information that's being presented to government. And if I move on slightly, so the Liverpool trial, if I can call it that, in inverted commas, can you describe the research protocol that was used to collect those data and which Research Ethics Committee approved that study, and give us an update on the outcome?
Professor Whitty?
Well, I think so. I think you're probably conflating several different things, and I think it's important to kind of separate them out. What we're trying to do in all 4 nations is to try out a variety of different approaches to minimise risks for the population. Some of these things will be done as part of formal trials in the kind of classical way. That is particularly true for drugs, which absolutely have to go through very strict ethics things, because of giving people things that actually can do them harm.
Can we please stick to the area that I'm asking about? I'm asking about the use of lateral flow tests specifically for test and release, and the clinical data from the Liverpool trial and how that supports the current strategy.
So I'm trying to answer the question. Trials of lateral flow tests happen to be one of my own specialist areas, so it's just something which I do understand reasonably well. So I just wanted to I'm trying to lay this out. The thing to understand with these kind of lateral flow devices used in almost all settings. I'm not just talking about COVID, and I'm not just talking about the UK. So it's just as true if you're talking about lateral flow tests for malaria in Tanzania as it is for COVID in the UK now, is what you're trying to do is minimise risk by trying a variety of different things where the operational questions are one set of questions, the what do people do behavioural side is another set of questions, and the sensitivity, specificity and use of how the tests work under operational standards are a third set of questions. And one of the things we found with the Liverpool study, for example, is that the operational sensitivity is lower, possibly unsurprisingly, than the operational sensitivity that you would get under ideal laboratory conditions. Now, that's an example of the kind of thing which it is very important to identify and then to feed into what you subsequently do.
But we know all of that, Professor Whitty. With respect, I'm trying to get into what is the reliability of the evidence from the Liverpool study. The only information that I can find of that about that is, sorry, my screen's just gone off, is in the back of the community testing, a guide to local delivery, in Annex B of that document. It states that in the Liverpool study that the lateral flow test missed 50% of PCR confirmed cases and missed 30% of high viral load cases. But certainly my concern is that if population are being advised based on those data that it's safe to be tested and then to go out into the community over Christmas to engage with vulnerable relatives, what evidence supports that it is safe to do that? So,
okay, so now I think I understand the point you're making, and I firstly to say I agree with the general kind of thrust of what you're saying. The thing to understand with these is, as with so much of COVID, the idea perfection is a zero possibility. So what we're trying to do is find imperfect solutions that are the least imperfect we can get. Now, if you're using an imperfect test to reduce risk, then you're going to be doing something which is helpful, and if you do it in a way which is going to increase risk, you're going to make it actually unhelpful. That fundamentally is the issue. So let us say people were going to go to the supermarket anyway, or the hairdressers, let's say the hairdressers anyway, and you do a lateral flow test with a 50% sensitivity, and people who are positive do not go to the hairdressers, you're reducing the risk to the hairdressers and to the other customers by 50%, not by 100%, but by 50%. So if what it's used for is to reduce risk, then the lateral flow tests have a very substantial benefit. If, on the other hand, what they do is they're used to increase risk, then obviously that is, so people start doing things they otherwise wouldn't have done in a very risky way. They start using this to do things in a risky way, then it becomes a lot more complicated. And that's really what a lot of this is about, is trying to work out under what situations will it reduce risk, under what situations will it increase risk, and basically where does it make almost no difference. And all three happen.
Thank you. We're going to come back to testing in a bit more detail.
That's a much more circumspect, and I think a balanced response, and I certainly in Scotland I think the advice that's been reflected there is in that balance, and my concern is that is not the message that's being transmitted by the Secretary of State.
Okay, thank you, Neil. We'll go to Luke Evans, then Aaron Bell.
Thank you, Chair. Dr. Harries, Prof. Whitty, Prof. Vallance, can I just say a profound thank you for yesterday to getting the vaccine into the place where it should be. Given all the evidence we heard at the start, that's an incredible achievement, and I'd like to thank you sincerely for that. My questions are about the modelling. We hear a lot about particularly SPI-M and the modelling that goes on there, but I'm more interested about SPI-B. So this is for Professor Vallance. Could you explain the balance between the data modelling and the behavioural modelling that SAGE use?
Well, as you say, SPI-B is the behavioural group which has been working from the beginning of this. And at SAGE, we get inputs from both of those groups and indeed other groups as well. So whenever we're considering a problem, or where it's appropriate to do so, we will try to get both the mathematical modelling and the behavioural input into that. And very often, we'll put a subgroup together that might work between those groups plus other groups to try and come up with the advice when we can. So we're trying to insert behavioural science into most of the decisions that are made, and that takes place at SAGE.
Between that, could you comment on the weighting between the modelling that you see and then the actual behavioural aspect that happens? And this is a lessons learned. Has that changed over time, that we're using more behavioural modelling given we know how people react to lockdown?
The balance, I think, is a difficult one because it's not a sort of it's rather situation dependent as to how much information we've got. But what the modelers will often do is say, the biggest unknown I have in my model is the behaviour. And therefore, how can I get a handle on what that might look like? There are some studies that look at that. So, for example, one of the models that comes in through the SPI-M group is the COMIC study, which actually looks at contact patterns. And we get information also from the ONS study, which starts to look at some behavioural aspects as well. So we do get some data. And then there's also the body of knowledge through behavioural science, which doesn't then deliver data, but it delivers experience, understanding, insights, and so on from what they've seen before. And that will also feed in. And yes, it's got better. I mean, there are more... There's more data that's arriving now, but it's still very imperfect. I mean, trying to predict behaviours is, with a sort of mathematical accuracy, is something that is fraught with problems, and it creates a lot of uncertainty in the models.
Does that? We've seen the tier system change several times. How much has the behavioural influenced those tiers?
Well, we've given behavioural advice at every stage. On this. We obviously don't design the tier system, that's a policy choice, but we try to give behavioural insights into what the impact will be. And so, for example, one of the things that ONS told us recently was that the adherence seemed to be actually much greater in tier 3 than it was in lower tiers because of actually people understood things better in those tiers. So that sort of information would feed back, and the way in which we think certain things will be received and the unintended consequences. Because one of the things that I think we've seen throughout this is you can get, of course, unintended consequences of certain suggestions and indications and actions that take place. And I think trying to get that clear is one of the things that we look at as well. But I absolutely don't want to give the impression that we've got good data sources for these, because we don't for the behavioural stuff.
Thank you. Finally, Luke?
That leads me on to looking forward. When it was mentioned by yourself and Professor Whitty, as the vaccine starts to roll out, when we get to 10%, 20% of the population covered, how does that impact the behavioural aspect around the MPIs and the implications there? What modelling have you done about that impact?
Sir Patrick?
Well, we're looking at both the impact of different degrees of vaccination on the overall epidemic. So whether it's just the vulnerable people, whether there's a transmission gap and so on. And the behavioural science group are looking at what the behavioural changes might be in response to vaccination, and that work will then come together for us to look at. But one of the things that I think is clear, and the behavioural group have been really consistent on this from the beginning, is the messaging around this becomes incredibly important, as it does in most of the other areas. And there are some principles of communication around that which I think will be important, and the behavioural group not only have written papers on this, but increasingly are using the method of giving teach-ins to allow people from different departments across Whitehall to come and sort of hear it live.
The worry is
Finally,
that as people see more people vaccinated, the concern is their behaviour will change and become more lax. What's your response to that? Thank you, Chair.
Well, I think that's one of the risks that people, I mean, and Chris has already alluded to this earlier. I mean, the biggest risk we face now is everyone thinks this is all over. And it isn't all over. We have a very important light at the end of the tunnel with vaccines. We've got a lot to do to roll out the vaccines. We've got a lot to do to make sure the vulnerable are protected. We're a long way off yet knowing how we can move it to the rest of the population. That's dependent upon things like, does the AZ vaccine get approved? It's not the time to suddenly say we relax everything. And then if that happens, we will have a big surge.
Thank you very much indeed. Aaron Bell.
Thank you, Chair. Thank you both for your time today, all three of you, in fact. So, Patrick, you were talking about the ONS just now. Did you see the reporting yesterday from ITV, from Robert Peston, about the retrospective changes to the models of daily incidents in England? Do you have any comment about that? And does it concern you at all that the model seems to be so volatile when being corrected?
Well, I think the ONS issued a rebuttal and explained what was going on there. I think it's quite important to know that I think that point is specifically about the incidence modelling,
yes,
which is obviously one bit of it.
Yes.
And incidence modelling is by far the most difficult bit to get right, and it's bound to jump around a bit. It also, I think in the way they do it, that looks back over a sort of 6 to 8 week period and averages over that period. So it's going to change on a rolling basis. Much more important are the data on the percentage positive and the number positive that they get in that study, to be able to look at the prevalence data, and that's the reliable bit that we want to look at. And the data were clearly showing, for example, at the point that intervention was speaking to, that levels were going up at that time, numbers were going up. So the incidence modelling, I mean, modelling is always modelling, and we try to look at data where we can rather than just the model.
Yes, I mean, yes, of course. Which is the bit where Mr. Peston, I think, got a little bit confused, if I'm honest, is implying that it was just the ONS data which was driving all the decisions in government. That is completely a misunderstanding of it, and I would like to just correct that. And just to give you, I'd just like to give you some numbers of people who, for example, and I could do the same thing for people in hospital, people in ITU, people who died sadly. But let's take people who are on oxygen. 1st of September, 181. 1st of October, up to about 790. By the time you get to the 14th of October, where Tier 1 was considered, 1,752. By the time we get to the 31st of October, when Patrick and I were put in public to discuss this, 3,626. And by the 5th of November, when the new things came in, 3,954. And by the 20th of November, when the numbers had carried on going up, because there's always a lag, 5,140. Yes. Now, those data are hard data. Those are people in hospital on oxygen. So I think it's very important that people don't just think it's all theoretical modelling. No. I think a lot of this, and certainly from my perspective, my advice has been based as far as I possibly can on hard data of this is what is happening to patients, this is what is happening in the population. These are not modelled, these are real people in a bed unwell. And we really do need, I think, to understand that lots of different bits of information come to.
Thank you. I just wanted to get that on the record because it's obviously out there.
Yeah. If I can just add one other thing, if I may. The other way to look at this is in August, COVID was the 24th commonest cause of death in the UK. In September, it was the 19th commonest cause, and in October, it's the 3rd commonest cause.
Right. Looking at the tiers and the second lockdown, firstly, did we have enough information about how well the previous tiers were working? You've both obviously spoken since about the need to strengthen those tiers, and specifically around hospitality, because there's been an awful lot raised about that. Have we properly modelled the changes that the hospitality industry made in the period between the initial outbreak and over the summer to become COVID secure? Were those modelled appropriately when we then considered what we did with the different tiers, both pre-second lockdown and the tiers we're currently with? Sir Patrick?
I do not think we have got very good models on exactly the impact of different environments and different locations. I mean, I don't think anyone has. So if you look at the data around hospitality, what you have is a series of environmental factors, such as the fact people can't wear masks. By definition, you're meeting with lots of people who you don't normally mix with. You're in an indoor environment. In some cases, ventilation may not be adequate, and so on. So you've got the environmental factors. The second area is that when you look at case control studies, and they're not very strong, but they do suggest that there is an increased risk in those settings, much stronger if you look at occupational risk, where you can clearly see there's a risk to those who work in hospitality, again suggesting that there's a risk there in that particular sector. And then if you look at outbreak data from across the world, and you see events from specific hospitality environments where you see super spreading events and outbreaks. So there's a range of data. It's just not possible to model all of that with any degree of accuracy and say what differences is there now from
Sure, but you say the data from across the world, but we put in specific, the Public Health England put specific COVID secure guidance for restaurants and other hospitality venues to follow. Have we got data that is directly relevant to the UK rules that we are using to feed into what we're doing with the tiers now? We
do not know. I mean, first of all, I think it's brilliant. Actually, the hospitality sector has adopted those rules and done it really well. That's really important. We do not have data that shows exactly what the impact of that is in a measurable way. It's not possible to guess it.
But if you look around the world, very few places have managed to control things whilst hospitality has been open and unaffected. Yes, and I think what the hospitality industry has put in place, firstly, has allowed there is some activity in the hospitality sector in the lower tiers, and it will make it easier to open things up in a safe way earlier than if those were not in place. So the actual, as an insurance to that, actually this is going to allow us to open up as the vaccines and the change of the season and so on improve things. This is not wasted effort, and I would completely join Patrick's view that we really admire and appreciate what the hospitality industry has tried to do. In a sense, this is just, unfortunately, we have a virus which thrives by bringing people together from different households indoors, and the hospitality industry, that is what they do as part of their business model, which is why we all enjoy it so much. So I think that's the problem we really have with hospitality industry, and this is a global issue. And again, you could look everywhere around the world. Every country that's got strong science has come to the same conclusion on this. This is not a UK thing.
France, Germany, and so on. And I think the other thing to say is that when you look at the effect of the tiers, it was only when hospitality was shut that you could see the cases coming down. So again, it's all circumstantial evidence, but it's a points in the direction that Chris has alluded to, and that's the conclusion that I think countries across the world have come to.
Thank you both.
A lot of people who work and owe their living to the hospitality industry are frustrated that they don't see the forensic level of evidence that justifies, for example, the particular curfew hour, and feel that it has a major impact on their lives and prosperity on the basis of evidence that can be ambiguous and not very deep. What do you say to them? Is there something that can be done in the structure of scientific advice that can be a bit more forensic about those interventions that have a very big impact on certain people?
Well, we're trying very hard to get data, and it's of course not an experiment because you haven't got the randomization. It's necessary in some cases to look at cases and controls, and those things are fraught with difficulty to make sure that you've got the right matching of those subjects. So much as we would love to get really detailed information on this and to be able to give you the answer, we can't give specific data on that other than the things I've talked about, and nor can anyone else across the world. But it's a summation of association and the evidence base I've described, which points to that being a sector that is particularly likely to be part of spreading. Now, it's not on its own, and there are many others, of course, that do that. And in all of this, the challenge has been which bits are you prepared to keep open, knowing that every single bit carries some degree of risk with it, and at what point do you want to stop? Because there's always a case in every area to say, I'd like this bit to be open, I'd like that bit to be open, I'd like to have more of this, and eventually you end up with the disease spreading. Now, in terms of curfews, I think that's even more difficult to say, and there's no really hard evidence on curfew times.
So why did we introduce a curfew?
Well, I think what you can see across Europe and indeed in this country is the notion that actually keeping people together longer in an environment, keeping people together longer in an environment where there's also alcohol, is likely to increase risk, and therefore that was a policy decision around trying to reduce the potential of interactions. It's not something that you can model with a degree of accuracy and say a particular time will give you a particular result.
Okay, thank you. Catherine Fletcher.
Thank you, Chair. Dr. Harries, gentlemen, I hope you had the opportunity, perhaps not in hospitality, but to sit on your sofa and take a quiet moment of reflection at the triumph that's occurred in this last week, you know, from a multidisciplinary effort. And I will quite happily buy you a glass in hospitality in the future when the opportunity arises. I want to turn now slightly to the response of people to these restrictions which have been keeping us all safe. What have you learned about the public's tolerance for these kind of restrictive non-pharmaceutical interventions, as you call them? Perhaps Professor Whitty first, and then Dr. Harries?
Well, I mean, I think that the biggest thing, which is extraordinary, is the fact that the British public have responded, as they always do in emergencies, with extraordinary generosity to other people and altruism. Because lots of people have considered that their own risk is probably relatively small, but to protect others, they've taken really dramatic changes to what they do that have affected them socially and in some cases, as we've just been discussing, economically. And they've done that to protect other people who are vulnerable, to protect the NHS, to protect the lives of other people. Now, of course, some people will also do it, hopefully, to protect themselves and their families as well. But the altruism of the British public, I think, cannot be understated on this. And it has been long-standing. It's gone on for a long period of time, and people are still doing it. And that is, because of that, many people have been saved who otherwise would have died of this disease. So I think the line of sight between people taking those actions collectively as society in all 4 nations of the UK and people not dying is absolutely clear. So I think it's a huge thanks that we all owe to everybody in society who has done this over such a long period of time. Now, of course, the longer it goes on, the more people are kind of going to think, well, look, you know, when will this end? And I think there are 2 possible responses to the fact that we now have vaccines. We're heading into spring of 2021 in much better shape than we were 3 or 4 months ago. The first response is to say, well, that's it, it's done. That would be disastrous, because then actually the wave would come back again incredibly quickly, and we're all very nervous about January and February, which is the highest risk period for the NHS. In particular, March as well. The alternative is to say, actually, there is an end to this, but we've just got to get ourselves through this last period. And we really must be self-disciplined, as we have been all the way through this year. And I think what all of us would say is, please take the second of those approaches.
So does that imply that you are seeing some of the public's tolerance for these restrictive practices starting to wane, and you are urging people to just stick with it for the last few steps? Is that fair?
Well, I think some people, but I think what is interesting is the degree to which, if you look at the actual behaviours of people, if you look at the polling about what people are intending to do, it's the degree of stability of people's decisions that they wish to do this that is so impressive, actually. Of course, you'll always find some people who are pushing the boundaries. I could cycle around London and probably find somewhere I could take a photograph and send it to the newspapers that showed lots of people crowded together. Of course, you can do that in some places, but overall, the response has been consistent across the country, across all parts of society, and prolonged. And that has been, remarkable, and that has saved a lot of lives.
Wonderful. Dr. Harries, anything to add?
And thank you. I mean, maybe I think we can see some of these effects. If we look at the face covering use, for example, I think people have gradually, with increasing evidence around transmission, have adopted those. And it's actually very unusual now not to see people wearing a face covering in those areas where it makes sense to do so, where we're in confined circumstances and meeting other people. I think there are some groups, so I do a lot of work on the clinically extremely vulnerable group, and I recognise there that actually a slightly different position has occurred. Some have been wanting to be out in society more, others have found it very difficult to come out, and I think we need to recognise there are very different responses in different groups. But a bit like CMO, I think we've also learned about the really important role of community leaders as well, whether it be directors of public health or some of the religious leaders in communities, and how important that is in encouraging local people to help them understand some of the reasons for the NPIs, but also helping us to help them to stay safe. So just adding to the point CMO's made.
Catherine?
Oh, that's brilliant. It's actually quite a good segue into the follow-up question. So this is a hearing to look back on evidence that we've received previously. And I was very struck by the evidence of the behavioural modellers that are part of Sir Patrick's scientific advisory team, and thinking so early back in March and April about how to keep people's tolerance for these public measures going. And the word that came up time and time again was, it must be fair. So I wonder, Professor Vallance, what have you learned about how to make measures feel fair to individuals in the country so that they can respond in this collective effort?
Sir Patrick.
Yeah, well, I think you're absolutely right to highlight how early and clear the behavioural group were about both construction of interventions, and fairness was certainly one of those things that they kept raising, and also how to communicate these, where they've also, I think, been impressive and consistent. And they've said right from the beginning, you've got to engage people, you've got to co-create the solutions and the ways that you deliver them so that people feel part of it. You've got to have special care to look at ethnic groups and also certain other hard to reach groups to make sure that you design things appropriately. Importantly, you need to explain the underlying reasons behind things. There needs to be simplicity, clarity and consistency, and where possible you need to enable people. And the example of the enabling one I think is really important when it comes to things like isolation. I mean, it's relatively easier to self-isolate if you're in a job that allows you to work from home and you can sit in your bedroom or office or wherever it might be and do your work and still get paid and still perform in the way you wish to. It's clearly very different if, as a result of you isolating, you don't have a job during that period, you're not being paid, you can't contribute. And as a result, you will have an inequity in the ability to do something which is a fundamental part of this response. And so that's why I think the behavioural advice was clear right from early on and remains consistent, that you need to enable these things, and the enabling to try and reduce the unfairness where it inevitably exists is an important part. The other thing I'd like to pick up on, on one of the things, I mean, very early on we made the statement, which I think remains starkly true today, that this virus feeds off inequality and feeds inequality. It makes inequality worse and it feeds off it. And I think that's a really important part of the fairness thing which was flagged up earlier on.
Thank you. Catherine, finally.
Yeah, thank you. I think we all agree that lots of people in lots of different ways have hugely done their bit. A lot of concern about different areas being in different tiers often comes back to a sense of fairness about public measures. Is there any reflection you would make about helping to build the case for what's fair to each individual area? Perhaps, I'm sure you've heard this, but more rural areas next to areas where there are higher concentrations of disease, it feels unfair. Is there more we could do if God help us not, no thank you, another pandemic comes along to make that messaging clearer?
Sir Patrick.
Well, I think there is something about explanation, but I think what you're also touching on is the question about sort of geographical boundaries, and that really is not a science question so much as a political one as to where the geographical boundaries are. And clearly, wherever you're going to have a boundary, there's going to be an issue either side of it as to whether somebody's in exactly the right one or the wrong one. So I don't think that's a science question, but it is. I do think there's an explanation piece which you've raised, which is important, but I don't think the question of how the boundaries should be drawn is primarily a scientific one.
Can I add, because I actually have to do the initial analysis that does this, along with many colleagues from JVC, and the decision about how big the unit of decision is fundamentally, in my view, a political decision. So should this, how small should the area be? Although if you make it too small, you're asking for trouble, because if you have a very small area that's got low rates surrounded by an area of high rates, we've tried that experiment several times and it always ends up the same way, which is the small area with the low rate gets a high rate. It's the way it goes. So I think that what we need to do is, political decisions need to be taken about the unit of that's appropriate, and a lot of that is around organisation and around the human geography of things. Those are decisions for local leaders, national leaders to make, and then you can actually say, well, within those kind of patchworks, this is where it's very high and this is where it's very low. But as Patrick says, there will always be people just one side of the boundary and just the other, both of whom will complain that actually this isn't quite right for them. As there are for every single one of the decisions we have to take. All of these decisions, you can always say, why have you drawn the line here? And the answer, you could have done it slightly higher or slightly lower, but you'd still have an equal problem either side of just being a slightly different place. So I think that's really what we just need to accept, that there is at some point the line is being drawn, and that boundary is going to be tricky.
Thank you very much indeed. Next we have Taiwo Awatami, but I think my co-chair Jeremy Hunt wanted to come in with a couple of questions.
If I could, this has obviously been a very tough year, and I just wanted to start by putting on record my thanks to both of you for your incredible service to the country over the course of the year. And I just have one question, which I'd like to ask both of you, if I may. We have learnt an enormous amount this year. I just really want to ask you what you think you have learned the most, particularly if you look back right to the start, to the advice that SAGE gave between January and March. What would you do differently, both in terms of the content of the advice and also the structures around which that advice was given? Maybe I'll start with Professor Whitty.
Thank you very much. Can I divide that into kind of three different blocks? Because I think this is an absolutely fundamental question, given this is a lessons learned inquiry. There's a block of things where the science advice we and many other people gave, with the benefit of what new science, we would give different scientific advice. An example of that might be mask wearing, where our advice initially was, actually, we don't think this is going to help much. Our advice now is, actually, we think this is a useful part of the tool. The science has actually changed. In fact, the data hasn't changed much, but the scientific interpretation of the data has changed in that particular example. And there are a series of answers where it is that we have new science. We know more about this virus. We have a better understanding. Then there's quite a lot of areas, and I think many of the areas that are most contentious are the fundamental scientific understanding wasn't incorrect, but the data streams were incomplete, and therefore if you basically start with incomplete data, you end up with incomplete answers. And I think the classic example of that is the question of when should lockdowns at various stages, which wasn't a single event, it was a sort of a rolling event, what was the optimal time to do that? And also questions around people coming into the UK from around the world, where should be quarantined, where should not be. The problem we had on the quarantine side is we didn't actually realise how widespread it was in Europe, for example, because there wasn't testing in many of the European countries. We knew it was in Italy, we didn't realise how expensive it was in Spain and France for a while. That's an example of a lack of information. Internally, because we had pretty limited testing capacity, in fact very limited testing capacity, we didn't realise quite how far along the curve we were, because we were having to use people who intensive care and who had sadly died, which is quite a late event. If we had the capacity on testing now, then we'd have come to very different conclusions using exactly the same science. The science isn't different, but the information that goes in. So I think that's a very strong, and I think if I look back over both this pandemic and over Ebola, which I also was very heavily involved in West Africa, lack of testing was one of the biggest barriers in both of those situations to being able to make rational decisions early on. And so I think one of the big learnings I would have from that is we've really got to build our capacity to turn testing not from the initial science to the test. We were really strong on that, and pay great tribute to my PhD colleagues, getting tests done experimentally right early on. It's then the big scale up and the capacity to do that at scale. That side of things, I think we really need to think quite seriously about, because that's going to be a problem. Any pandemic we have in the future, that is going to be an issue again. So I think we need to not find ourselves in that situation. We've been caught out twice now with lack of testing, and I think 3 times would be too many. So, I could go on, but those are kind of... And then the final thing is the question about structures. And I think on structures, broadly, I actually think our structures have been pretty good compared to where we might be. SAGE has had some difficulties transitioning from something which gave a small number of sessions, and I've been involved in SAGEs for a decade now, and most of them last 2 or 3 meetings, and were just to advise COBRA. I think Patrick might want to talk about this. Having a continual process, I think, has stretched the system, and I think there's quite a lot we could learn about that. So there's a process set of questions, but broadly the building blocks, having the NIHR, having the NHS, having the MHRA and so on, I think our building blocks have shown their capacity, and I think the early part of this discussion, I think we should in a sense, we should celebrate the things we have got that are good, whilst actually learning some of these things that I think we clearly would have done differently with different capacity and different knowledge early on.
Thank you very much.
Well, first of all, I really agree with what Chris has said. I want to add one point to the testing point, which is I think the other capability area was not just testing, but actually the ability to do contact tracing at scale, and that requires people in place, trained, ready beforehand, and that's one of the lessons, of course, that SARS and MERS taught in some places, and they had that public health system that enabled them to do that at scale. So I think that's one of the bit points I would add to that.
Can I just add that there is a view, and actually, co-chair, correct term, you've expressed it yourself, that the reason that we weren't doing contact tracing at scale early on was because we thought this was flu and it was actually SARS. I think that's a misunderstanding, and to be clear, I'm not a flu doctor. I'm an infectious disease epidemiologist in general. I've dealt with large numbers of infections, and the last one I had to deal with at scale, Ebola, was entirely based on contact tracing and isolation. So I fully accept the absolute need for that. It was basically a capacity compared to size of problem issue. And that's not the kind of thing you can, it's very easy to be wise after the event and say, why did we not invest in this previously? Just as it's easy to be wise after the event on multiple other areas. Actually, I think that the speed of the upswing that happened early on would have overwhelmed any realistic scale of contact tracing we had. Nevertheless, I think for future, this is an area we probably need to have greater capacity, and I think Germany in particular has shown how this can stand you in good stead, even in a European context. I think some slightly shaky comparisons are drawn with the eastern part of Asia, where I think there are a variety of reasons the parallels are not very exact, but I think the German example is a very good example. But even in Germany, even with experience, they are now struggling a bit with the numbers of cases that are happening in winter. So I think what we need to realise is that there is a sort of scale problem. At a certain point, however good your system is, it's going to get overtopped by the scale of the epidemic. And I think we shouldn't try to pretend that somehow you can build a perfect system. Classically, when you try and build a perfect system, you end up with some kind of variation of a Maginot Line. Very expensive, doesn't work.
Yeah, just to now answer the other part. I think there are 3 things I'd pick up on. One, I think, is really important for all resilience areas, which is very early on, we were dealing with imperfect data. Now, you're always dealing with imperfect data, but we were dealing with data which just we couldn't get our hands on enough of it. It wasn't interoperable. It wasn't linked in the way it needs to be linked. It's much, much better now. So I think the lesson from that is if we look down the National Risk Register and ask the question, what are the data sources, data flows, data owners, interoperability that you would want in order to look at the, top 10, have we got that in place? So getting that in place early, I think, is an important lesson. The second point is science advice is science advice, but it needs to dock into the machine appropriately. And I think it's not always easy to dock into all of the right parts of the machine. And as Chris said, it's somewhat easier when you're dealing with a 3-sage meeting with 3 COBRA committees and the system's trying to respond to something fairly clear and straightforward in terms of the output that you're requiring. It's much more difficult to get that right across the whole of Whitehall on a continuous basis. And so ensuring clarity of docking mechanism is important. And one of the things that we have started, which I think has been important and successful, is actually to get open teach-ins across Whitehall from some of the experts and science groups to come and talk to whoever wants to come to hear it, as well as the clarity of docking into Cabinet Office and other places. The third is duration. I do not think that we were well prepared for duration of SAGE stand-up. And the consequence of that has been that in the Government Office for Science, for example, we've had to rapidly build numbers to try and cope with this long-term problem. We didn't have necessarily the right surge capacity to get that right. And when I look at the people who've worked on both main SAGE and the subgroups, who've now been at it since January, who are full-time academics with research and teaching commitments and all sorts of other things, to provide them with some sort of resilience and support for what they need to do, I think we didn't have in place. We've had to make it up as we go along to try and support them. They've been heroic, and I want to get it on record here. They have really worked enormously hard on this and given up, all of them doing it for nothing. And their universities have also been supportive. You know, I've had to phone up people in the university, and they've all been supportive to say, yes, these people must continue. But I don't think we really knew how we were going to support them from the beginning over a very long period. And I think that's an important lesson to learn.
Thank you. Perhaps Dr. Harries, you might just give some personal reflections in the same vein as your colleagues.
Thank you. So I think I would reflect many of the same points that have been made. I think on some of the early learning about what we know now and didn't know then about the disease are significant. So I think we perhaps haven't got plans so much thinking through the risks of asymptomatic transmission as much as symptomatic transmission. So much of the design, I think, of our plans previously related to people who presented with symptoms and how we would manage them. So I think that's an important one for potential new respiratory viruses in the future. And also the point which CMO made around face covering, that relates very much to increasing and ongoing understanding around aerosol transmission, which starts to bring in points about ventilation and building design, which again I think might be something for us to focus on in the future. Other points for me, I think we've heard a lot about existing building blocks of the system. So in research, for example, how strong a position they put the UK in terms of continuing forward. And I think the one area certainly where I've been supporting clinically where that hasn't been the case before is for the social care system. It's very much easier to link up and roll things out and understand what is happening in the NHS than perhaps the social care system. So again, an important point going forward. And that links also to the point which Patrick made about data and digital flows. I think it's not just about the science, but it's actually about evaluating change so that we can put in interventions. So, for example, if our basic data doesn't have records, strong recording of ethnicity or learning disability, when we start seeing groups which are impacted differentially, trying to understand what the appropriate interventions would be to protect increasingly as we go forward through any disease becomes that much more difficult. So again, digital and data flows, I think, are important.
Thank you very much indeed, Dr. Harries.
Benny's just said, both of which I think, and inevitably, of course, I completely agree with the point he's made. The first is this issue about asymptomatic spread. And this is an example, actually, where we drew comfort, wrongly, from SARS, actually, So in SARS, the great majority, if not all of the transmission, was from people who were symptomatic. And whilst we accepted that asymptomatic spread might happen, we thought it was much more likely that almost all of it, or the great majority, were likely to be people who are symptomatic based on the fact that SARS had been like that. And that was an error of understanding. Now, still the majority is probably people who at some point are symptomatic, but the idea of pre-symptomatic spread, I think, was something, although we theoretically thought it might happen, I think the importance of it was underestimated early on, not just in the UK, more widely. The second is just to really strongly endorse what Jenny's just said about social care, and I'm going to take research as the area. Social care research in the UK is nowhere near as strong as we need it to be. So there are many areas of science where our research is outstanding, as we discussed, and feel very proud of that. But social care is such an important part of the health and social care system. And if you look at the amount of research that goes on in that area, there's far too little of it. It's perfectly respectable, but it's far too little of it, and we really need to look at that, I think, and look at that across the board. So I think that's an area in science terms we've now got to take really seriously.
We're going to come on to that a little later, if we may. Let me go to our colleague Taiwo Awateme.
Thank you, Chair. And I would just like to put on record my thanks to the panel and all the multidisciplinary effort and achievements. Professor Whitty, my question is about public health messaging. In March, the public health message was stay home, protect the NHS and save lives. And that was understood by 90% of the population. Now, in May, the messaging changed to stay alert, control the virus and save lives. And that was only understood by just 30% of the population. What lessons has been learned throughout the pandemic on the importance of having clear and consistent public health messaging?
Well, I'll give a view. Patrick will want to give a view as well, and Jenny may well as well. I mean, the problem the first thing to say is we can't take credit for the kind of the slogans that worked, and we can't take blame for the slogans that didn't, because communications is not our great strength. But there are many people who are, in terms of actually these kind of actual campaigns. But I think you are absolutely right that the clarity of the initial message was really clear and absolutely essential to people understanding what needed to happen and then doing it. So I think you are completely right. And having complete consistency of message, and this is an area which is quite tricky operationally for us, because this has gone on for a long period of time. If you look around the world, there are places which have had just the same person doing the communications the whole time, and there are places where actually a group of different people have taken turns at it. We've taken in England slightly more the second approach. I have to say, if I was one of the people who'd have to do it be the person doing it day in, day out, which is one of the possible models, it's doubtful I'd have had much time for anything else. So I think that there are some real operational difficulties to that. So there's a question about, have you got the message, a good message, and then there's a question about consistency of messenger, because the same people tend to actually have a particular messaging style. So I think there are quite a lot of things we need to look back on and ask the question, which bits of this worked and which bits of this simply confused people. And I don't think I'm the right person to do this. I don't think Patrick or Jenny would say they were the right people to do it, but I think we would all agree that there's a lot we could have, there's a lot that did work, but there's also a lot I think we could do a lot better. And one thing which Patrick said earlier, which I think we really, really need to look at again, is I don't think we got our messaging to some of the ethnic minority British groups right early on, and indeed some other smaller groups. And we just didn't actually have a clear campaign on those areas. And I think that is something which we need to look at fairly self-critically and work out how we could do that better next time round. It's still not perfect, but I think at least we're now got it a lot more systematic. But that's an area where I think all of us would look at and say, actually, could have done better.
Thank you. Taiwo?
Yes, just wanted to move on about communication regarding the vaccination. Now, polling has shown that 1 in 6 people are either unlikely or definitely won't be taking the vaccination, and this is due to their beliefs, some of their attitude and values regarding their skepticism around science. So in order for us to be able to achieve the vaccination aim, what is currently being done to address some of the recommendations by the Royal Society, particularly around having open and transparent messaging in order to ensure the public expectations are met, but also how do we empower the general population to be able to spot and report any misinformation?
Thank you. So I'll start because this is very classic Chief Medical Officer territory, but Jenny and Patrick will both have strong views on this, I suspect. I mean, I think I would divide, there is a very small group of people who have got very weird views about vaccines, and in a sense, they're not worth worrying about in public communication terms because nothing will persuade them that this is the right thing to do, and that's their right as competent adults to make those choices. There's a lot of people, though, who actually have quite legitimate questions of any vaccine and any medical treatment. Vaccines are no different to that. And what people want to know, I think, is three different things. First question is the problem I've got, either as a risk in the future, this is for vaccines, or disease now, big enough to do something about it? You know, if you've got a trivial problem and you're being offered a major operation, you're not going to do it. So it's got to be a big enough problem. The second question is then, does this actually work, as in will it cure the disease or will it prevent the disease? In the case of vaccines, will it prevent it? And that's where the efficacy comes in. What proportion of the cases will be prevented? And then the third question they want to know is, what are the side effects of this? Because drugs of all sorts, aspirin and paracetamol have side effects. Every drug has side effects. Vaccines will have some side effects. For sure, some people will have them. And what they want to know is, are those proportionate to the thing which it's reducing? And they need to have those, as you say, the Royal Society said it rightly, and I think we would all agree with this, as transparently and honestly as possible, so that people, aren't surprised, they actually can ask straight questions and get straight answers. And for example, my outstanding colleague, Jenny and Jonathan Van Tam, did a great job, I think, of answering lots of questions, but we'll need to carry on doing that as more information emerges. So, divide those three up. I think most people, certainly most people who are vulnerable, do think this is a big enough problem to prevent. And I think the efficacy data are really clear. And now we need to be really clear about any issues around side effects and so on, so that people feel they can make a balanced and reasonable decision. And I think, a lot of the people you're talking about who are just waiting to see, that's entirely reasonable. These are new vaccines. They're waiting to see, and I think with the right information, they will think, yes, actually, this feels right to me, and that's what they will do.
Thank you. Perhaps briefly, Sir Patrick?
Yes. I think I completely agree with the point about transparency and clarity. I mean, people want to make informed decisions and to be treated as adults to do so. And in order to do that, we need to be very clear about what the effects are, what the unwanted effects are. We need to be clear about when there are things that crop up that change any of those positions, and to do so in the most transparent way possible. I think that's the way we'll build confidence around this and build trust. And I think there's experience in other vaccine programs as to the importance of doing this. So I think it's critical, and to make sure that we do that in the right way for the right groups. And I don't think in some cases it's enough simply to say we've got our message and we've translated it into these languages.
Thank you.
We need to also deal with the other issues that may make people understand it.
It might be worth asking Dr. Harries, because this is also something.
Dr. Harries.
Yes, thank you. I tend to put my old Director of Public Health hat back on and think of it from the person upwards. So I think once we've got the national messaging clear and correct, what's really important is who is giving that message locally as well. So obviously we work with Directors of Public Health to ensure that there's a consistent message, but I think for the person in their home, in the street, primary care, their GP, but particularly actually the practice nurse, so working with them to ensure they understand as well. If healthcare workers and social care workers take up the vaccine, that's a very clear message to the public, and I think we've seen that actually on the TV screen yesterday. And one of the first lessons I learned as a public health director in South Wales actually was you need to find the critical person in your community. Now, in a South Wales mining village, the person you needed to influence was the grandmother of each family, and if they thought vaccination was all right, every single grandchild had all of their immunisation. So again, I think it's about doing both the national messaging but also the local as well.
Thank you. I'm sure that's not true just in South Wales. But Taiwo, any final point?
Thank you. Now, I just wanted to really ask about social media misinformation that's going around online. What is actually being done to address some of that? Because as a healthcare professional, I found in order to be able to convince any of my patients to take a new drug they've been prescribed, I had to be able to dispel some of their concerns about that drug. So what is being done to address some of that anti-vaccination conspiracy theories that's going on online?
Well, Chairman, I would divide it into kind of broadly three groups. The group which is, in a sense, the responsibility for Dr. Harries, for me, for Jonathan Van Tam, for Professor Vallance to address, along with many, many other healthcare professionals all the way through the system, is people who are asking very legitimate and reasonable questions about a vaccine which is going to be given to them, to their parents, to their children, and so on. And those questions should be taken seriously and should be answered honestly, as everyone, as you would agree, and everyone would agree. Then there are a group of people who have very, very strong views on vaccines, not always, let's put it this way, scientifically founded. And I think it's reasonable to actually address those as best you can, but accept that you may not end up with them coming round to agreeing with that. And then I'm afraid there are also some people who are deliberately going for misinformation, many of whom, bluntly, are not based in the UK for a variety of reasons. And that is definitely not a medical issue. That's an issue for others to take seriously. But that is a very serious issue because those people are deliberately trying to sow uncertainty about vaccines, which is in the long term not in the good interests of the citizens of this country. And that is not for this discussion, but it's just to acknowledge that that does happen for a variety of reasons, including a well-funded anti-vaccination movement in certain countries, and also other reasons that I think are widely known from the newspapers.
Thank you very much indeed, Professor Whitty.
Thank you.
We'll now go to Sarah Owen, then Graham Stringer, then Laura Trott.
Thank you, Chair. I just wanted to pick up a point that Sir Patrick made about emergency planning and preparedness before asking some questions about mass testing. Now, back in early 2000s, I remember multi-agency emergency planning discussions taking the contemplated mass deaths caused by SARS. I was relatively young then, and the prospect of mass burials really struck with me. Emergency planning budgets were cut by 29% from 2010 to 2017. Do you think we could have benefited from, and do you think we need in the future, greater investment and focus for emergency plannings for pandemics, especially with regards to testing and contact tracing?
Sir Patrick?
I think that I've said that if you look at what happened in some other countries, there was a preparation of some of those things after SARS and MERS that was beneficial. And so I do think that the public health system needs to be properly supported, needs to have the right ability to respond. And I'm afraid what we're talking about is resilience which allows spare capacity. And so one of the tensions, and we're outside science here, but I think one of the tensions in this is if you run a system which is at absolutely full capacity the whole time, you by definition have not got the surge ability to grow into something new. And so I think this is going to be true, and go back to vaccines, it's going to be exactly the issue that we need to face around vaccines. We want to have vaccine capability in this country. It's probably not realistic to assume that you have a big vaccines capability that sits there being kept warm, waiting for the next thing to happen. So somewhere between having nothing and having something which you unrealistically expect to be sitting there ready to use when you need it, but you might not need it for a decade or more, I think is where we've got to get to. And that's going to require the question about how much extra capacity you want, how you would fund that, and what you do to keep the bulk of that going whilst you know that you're only going to need the surge bit for certain things. And I think that's an issue for vaccine planning, but it's also an issue right across the public health sector, which I think would...
Thank you. Sarah?
And these questions are on mass testing, so I think probably for Professor Chris Whitty. Before summer, Luton was subject to higher restrictions, and a key part of us coming out of that was local contact tracing, but also Liverpool's also been trialling mass testing. Do you think we're going to have to continue with this capacity for mass testing, and how is that impacting things at the moment?
Well, I think that the approach that